I'm going to give a bit of a background to SAPRIN and what we are trying to achieve to SAPRIN and how this infrastructure actually works. So the vision mission of SAPRIN is to enable impactful population-based research through supporting a network of standardized longitudinal whole population health and demographic surveillance nodes in South Africa. And we've been going for about 4 years now, and we started with the 3 existing demographic surveillance nodes in South Africa, in Mpumalanga, Agincourt, in Limpopo, the Mamu site, and in KwaZulu-Natal, the Ari site. Already in 2019, we have been hosting more than 300 million rands worth of externally funded research projects, 59 studies, 561 jobs in those studies, and the SAPRIN infrastructure produced 165 publications last year and qualified 57 postgraduate students to show already the impact of this research infrastructure. And of course, the aim is to achieve policy impact, and we've seen some examples of that during the COVID epidemic, where SAPRIN was able, and also assisted by GRT Inspired, to make already some contributions to the knowledge around this pandemic. We've produced a standardized population data, and we are considered to be one of the leading institutions internationally on the curation and analysis of longitudinal population data. I've talked about the capacity building and the postgraduate students that are hosted in the studies and using the data produced by SAPRIN, but also a very important component is this concept of citizen science and how the population of these nodes are involved directly in our research, have a voice in deciding what kind of research is to be done and how that research is to be done. And that to me is also really an exciting component of an infrastructure such as SAPRIN. I'm going to talk a bit more about the evolution of SAPRIN over the years. We started, as I've mentioned, with these existing nodes. So that really, these nodes have been in operation, and in some cases, like Agincourt, for more than 20 years before we brought them together in SAPRIN. So we had basically a running start because of all the good work that have been done over years at these 3 existing founder nodes of SAPRIN. Through advocacy around the potential of these nodes, linking into a government initiative for a research infrastructure, a vision by the Department of Science and Innovation to find a funding model for research infrastructures that have a longer life and require greater investment that one can mobilize by existing science funding mechanisms within the government. SAPRIN, or a network of health and demographic surveillance sites, were identified as one such potential research infrastructure. They identified champions, and the first champion for this idea was my co-director, Mark Collinson. I joined him slightly later. And we then worked to, within this framework of the Department of Science and Innovation, to give substance to what the network would be, how it would operate, what the base research protocol would be for that network, and what funding was required and management structures to make it all a reality. And the key components were population-based multidisciplinary research infrastructure, policy-relevant information and shared data, capacity building, both in terms of research and research support, citizen science and community engagements were the pillars of what we conceived for this research infrastructure. We could bring together the existing nodes around this common purpose, and they were very actively supported by their host universities in that process. And we played a key role in supporting us and helping us to establish the network, specifically WITS, University of Limpopo, and the University of KwaZulu-Natal. We managed to be one of the first 7 research infrastructure projects that was funded in 2017. And so then we had the funding to make this a reality, and we could then establish the common research protocols for the sites and start to fund the routine surveillance activities of the nodes. And that is really important because sites such as these are not uncommon in the world. There are about just over 50 of them, but almost without exception, if you talk to these sites, they all complained about how difficult it is to maintain this infrastructure. They can always show how successful it is in terms of the nested projects, but the traditional science funders are always reluctant to invest in these long-term infrastructure. They are keener on the research projects that are answering a particular research question. And so that is the key factor in SAPRIN that allow us to be so successful in attracting additional research funding. Our national home, the South African Medical Research Council, we were very fortunate to have that support from the president of the MRC, and they've been an excellent host for us, and it allowed us to have a national basis from which we could proceed with strengthening the network and extending the network to the current 5 sites. In the meantime, we have developed standard data products, and you can go to the SAPRIN website and download the common data set. And we've developed training courses on how to use that longitudinal data and sort of the insight into the structure of that data. And we would be very keen to share that and organize such training workshops also at UJ for your students to be able to use that valuable data resource. And I've heard Professor Khan talking about the data institutes, and it may be an interesting collaboration that we should consider with them. National stakeholders are really important in this process, particularly Statistics South Africa, the Human Sciences Research Council, Department of Social Development, the department in the Presidency for Monitoring and Evaluation. These are all stakeholders that we work with closely and have formal agreements with to share our data with them, do joint analyses, and fulfilling that key function of triangulating the broad and representative data that you can get through national surveys with the very deep insights that you can get by really looking closely over time at the particular population. Now, of course, we are in this exciting phase together with you to expand the network and also to welcome you in our multi-node research communities of practice, where we learn from each other how to do better population-based surveillance and how better to support the research projects that we host on the network. I've already alluded to COVID-19, and I think that, of course, it is a tragic development, both locally and internationally, but it did show how having in place such a network could allow us to immediately offer valuable benefits to expanding the knowledge around this pandemic. And GRT inspired, and there will be some examples of how they've already done it. We've implemented a common surveillance protocol for COVID-19, telephonically based, in all the in the 3 other nodes, and we've just completed the joint analysis of that data, and the publication is being submitted as we speak about this. But we've also contributed on the national stage in terms of the funding, and particularly about the impact of the pandemic at household level in the rural areas where our current nodes are. Those data is made available through the National Forum DSI Observatory. I want to say a little bit more about population-based research and the specifics of the kind of infrastructure that SAPRIN creates and make available to interested investigators, researchers, scientists that want to make use of this opportunity. So we start with a geographically defined and spatially located population. And actually here, GRT Inspired is really unique in the diversity of the urban landscapes that you've brought together. And definitely, I'm sure, the world's first longitudinal population surveillance in high-rise buildings in inner city. I don't know of any other place where that has been attempted before. Of course, this idea of looking at a geographically defined population and understanding their health needs is not new. And in South Africa, already in the 1940s in Pulela, we saw that idea coming to the fore, and it has been very influential internationally or historically, leading up to the Alma Ata Declaration on Primary Care. But sort of the next iteration and development of this idea was in Matlab in Bangladesh, and that's the place where oral rehydration for diarrhea was shown to be effective. Niagar in Senegal, where the measles vaccine was tested for the first time in the 60s. And then through the in-depth network, more of these sites were brought together. And collectively, these sites have made huge contributions to our understanding of population dynamics and poor rural and urban populations, and has contributed extensively to the understanding and the combat of major diseases such as malaria, HIV, and tuberculosis. So from this geographically defined population, the whole population is monitored, surveyed and monitored over time. Currently, we have over 450,000 individuals in the SAPRIN network. It's an open cohort, and participants or individuals come into the cohort through birth and in migration, and they leave the cohort through death, at which point the verbal autopsy is done, and throughout migration. Actually, a special feature of the SAPRIN approach is that should the individual retain links to their home household or their original household, but move out somewhere else, we still continue to have that person under surveillance no matter where they are. And that has really allowed us to look at interesting phenomena around circular migration between urban and rural contexts, and the implications that that has for service delivery. On this basic population, then becomes a sampling frame or an intervention frame for further longitudinal observation or studies in terms of biomeasures, genomics, and linking the population to their service records, whether that's health service records, educational records, social support records, to really be able to not only show how the population is making use of services or what the outcome and impact of those services are on certain outcomes in the population, be it health or well-being, but also, and this is quite unique, being able to understand who is not accessing those services and what can be done to improve access along the ideal of universal health service coverage. So this infrastructure allows us to study various aspects of population dynamics, the cause-specific mortality, burden of disease of communities and how that is changing over time. I've just mentioned universal health coverage and the unique ability we have to do that. Of course, also quite topical within the current initiative around national health insurance. It allows us, especially by linking to the service records, to look at the determinants of disease and social outcomes, policy impact of particular interventions, or even experiments on interventions through clinical trials and other implementation experiments to provide evidence for policy. And then climate change impact, and it's quite exciting that there are a sister infrastructure to SAPRIN, FDON, that do environmental monitoring, and we are trying very hard to make sure that we collaborate closely so that in a particular geographic area we can look at the whole spectrum between the environment and the population, and be able to maybe identify and attribute the impact of climate change on health and well-being. We have standard protocol and data collection methods, as I've mentioned, and that allows then hosted studies to come into a well-described, documented environment. It really paves the way for multinodal studies, and we're really keen to encourage multinodal studies across all the SAPRIN nodes. We have an annual household visit, field-based computer-assisted participant interviews. We have a call center telephonic-based computer-assisted telephonic interviews, something that was extremely helpful during the COVID epidemic, because we could pivot our field-based visits during lockdown to move to completely telephonic data collection, and we were able to continue our operations in that way and offer that infrastructure also to some of the embedded studies within SAPRIN. And that has really over the last year come to its own and is really a key benefit that SAPRIN is bringing to the nodes. There's also clinic-based computer-assisted participant interview and record matching to attendees at clinics, and with health information systems like Tier.net and other medical record systems. Part of the protocol, although in the initial implementation at GRT Inspired, this component would not form part of it, but there's a potential to add that down the line, where we also have individual interviews and taking of specimens, specifically dried blood spots, on which we would routinely do HIV serology. But of course, that also offers the opportunity to do something like population-based COVID-19 serology. Verbal autopsies are done either through field-based computer-assisted participant interview or call center-based telephonic interviews. This is done using the standard WHO verbal autopsy instrument that has just actually been adapted to specifically identify COVID-related deaths as well. And that then allows us to, over time, look at cause-specific mortality changes within these populations. So I'm coming to the end of my presentation, just to then quickly summarize. So we have a 45-week data collection model, so continuous data collection throughout the year. Nodes can amend their platform protocol to not only include SAPRIN core data elements, but any specific items that they are interested in. We assist with standardized question wording, concept definitions. There's a common ethical framework with reciprocity of protocol approval, written consent, full disclosure, anonymized data, that we get consent for that data to be shared. And we produce SAPRIN level pro forma templates for nodes to develop site-specific memorandums of understanding with government departments for record linkage. And we assist with the electronic data quality assurance system. So at a high level, annually, we nodes contribute their data in a standard format to SAPRIN, where we combine that into the SAPRIN common data model to produce harmonized data sets, which through the help of the Center for High Performance Computing, and we share that on the SAPRIN data repository, and the URLs for the data repository is listed there, and we publish also some high-level population indicators that you can see on our website. Thank you very much.
The University of Johannesburg, the future reimagined.